E-N-A-R, thenar. That's my North Carolina accent. When I go home, I don't get all my relatives, they speak like freaking hillbillies. It's just odd. I don't know what happened. My accent's mostly gone. I mean, anyway. If this is the thenar eminence, that's the hypothenar eminence. I mentioned it earlier. The muscles over here have the same name. But it's that digiti minimi thing. Flexor digiti minimi brevis. Opponent digiti minimi. Abductor digiti minimi. I don't really care about these over here, other than to say that in ulnar compartment syndrome, those you have weakness of the little finger. The thing about the thenar eminence, though, that makes it so relevant is how superficial that nerve is I was telling you about. When you're taking and you're trying to open up a glass jar, and you're doing like this right here, and that jar shatters, what do you think is going to get cut? You're going to wind up with a laceration of the thenar. Anytime somebody comes in with a laceration of the thenar eminence, you better check those 4 things related to the thumb. Any questions?
You said that was the median, maybe?
Median recurrent is the specific name of that nerve. There's one more muscle that's very deep in here. It runs right across. It's like right there. It connects the 2 bones. It's called the pronator quadratus. It's flat, it's quadrangular, pronator quadratus, and it's deep. On one of the cadavers, or 2 of the cadavers, I'll do a deep dissection for you. I'll take all of the muscles and pull them out through the carpal tunnel, so you can see you can put your finger in the carpal tunnel, you can see the interosseous membrane, you can see pronator quadratus. I won't do it to all of them, but just a couple of cadavers. There's that median recurrent you see up there. How superficial it is. All right, here's the carpal tunnel right here. Here are all the tendons and the median nerve going through it. There's the ulnar artery and ulnar nerve not going through it, as well as the palmaris tendon of the palmaris longus. So you'll be hard pressed to actually take your finger and run between the curve of those carpal bones. It's that tight in there. So it's no surprise that it doesn't take much inflammation to cause problems in that carpal tunnel. You're going to see carpal tunnel a lot. Now here's the snuff box we were talking about earlier. The reason I wanted to delay the discussion of the snuff box is because the deep branch of the radial artery is also in there. If you put your finger right there on the snuff box, you can feel the pulse of the deep branch of the radial artery if you don't have fat wrists. Okay. Now they call it the snuff box because, you know, they would put snuff there and snort the snuff out of that little depression back in the 1800s. Long time ago, I used to have a roommate. A bunch of us had a house, and he was a football player, ex-football player at OSU, and he was about as wild a person that I've ever known. He would take, when you go out drinking with him, they would take, not they, I actually did it once. They would take, he would take, I took, whiskey and filled the little snuff box and snorted whiskey out of that snuff box. And you've done that? Very good. You've done that? Paul is... All right. When you elect officers, when you elect officers, we've just found the social chair.
It's like, don't knock it till you try it.
Don't knock it till you try it, yeah.
Do you recommend it?
You know what's that guy's name? Jackass?
Steve-O?
Huh?
Steve-O or Johnny Knoxville?
Yeah, Johnny Knoxville, they were doing a thing one time, they were snorting wasabi.
Oh my, I've seen that.
You see that? They were throwing up all over the place. Most sane people just recognize the historical importance and let it go at that. Okay. You want to know a really useless muscle? This is palmaris longus. If there's a longus, there's a brevis. That's the palmaris brevis. It is almost invisible. It's so thin and completely useless. Now, one of the things that I'm showing you in this illustration here is off the Flexor Digitorum Profundus tendons. There are these little cylindrical muscles, there are 4 of them, called lumbricals. They go to the 4 digits. They arise from the profundus tendons. And so if we look over here in this illustration, here's our superficialis, Flexor Digitorum superficialis. There's the Flexor Digitorum profundus going through the split to go all the way to the distal phalanx. On the extensor side, here's the extensor digitorum tendon. I said it went to the end, almost. It actually doesn't. It terminates in a tendinous sheath called an extensor expansion. And that extensor expansion is on the extensor surface of the finger here. And the extensor expansion is what goes all the way to the end. Now the reason this extensor expansion is unique is because the lumbricals from the flexor side go up and along the lateral part of the digit to insert into that expansion. Right here is the proximal phalanx. You see it coming up through there, inserting into the extensor expansion right there. This one goes up through there, this one goes up through there, this one goes up through there. You don't have one on either side of the digit, it's just one. Now, follow this. If the lumbrical is coming up this way, it will flex the MP joint, but it's pulling back on the expansion here at the proximal phalanx, so it will extend the PIP and DIP joints. It flexes the MP joint. Let me do this. It flexes the MP joint and extends the DIP and PIP. When you wave bye-bye, that's part lumbrical. Okay? I mean, you're also using your extensors and flexors to do it, but the lumbricals, that's the action of the lumbricals. That right there, and that right there. And that's what I've tried to illustrate with these arrows here. You flex the MP joint and extend the PIP and DIP joints. You also have deep in there, the deepest layer of bone, muscles, and they are next to the bone. You got to get all the way down to the bone to see them on the palmar side, but they're pretty superficial on the dorsal side. These are called the interossei. Oh, by the way, the lumbricals, let me go back. You remember yesterday when I was talking about the median nerve gets everything here but 1.5, this, that, or the other? The two lateral lumbricals are innervated by the median nerve. The two medial lumbricals are innervated by the ulnar nerve. And it's the same with the profundus tendon, the muscle. These two fingers are supplied by the ulnar nerve. These two profunda muscles are the median nerve. Those are the exceptions from yesterday. So the interossei, all of the interossei are innervated by the ulnar nerve. You have 7. And they run from the metacarpals to either side of the phalanges. Remember on day 1, I said that abduction and adduction were related to the midline except for the hand. When you look at the hand, you use the middle finger as the focal point. So this is abduction of the fingers. This is adduction. That's the action of the interossei. And the mnemonic device to remember it is the palmar interossei adduct, the dorsal interossei abduct. If you look on the illustration there, you can follow that. Pad and dab. When you put your thumb, when you realign your thumb, that bulge right there is your first dorsal interosseous. Right there. In neuromuscular disease, like wasting diseases, like Lou Gehrig's disease, where you have the nerve is gone, the muscles have to have an innervation or they degenerate. The muscles, they atrophy. They don't degenerate, they atrophy. In Lou Gehrig's disease and other demyelinating diseases, one of the first places you see it, the muscle wasting, is in the first dorsal interosseous. The other places where it's apparent is in the thenar eminence. So if you have a person complaining of where Lou Gehrig's disease, or ALS is the medical term, amyotrophic lateral sclerosis, ALS, you can Google it. As you look at those muscles, you can see in this illustration here that the first dorsal interosseous is gone right there. And here there's thenar wasting here versus right there. Now the same thing could happen with damage to the ulnar nerve in the case of the thenar eminence, or damage to the ulnar nerve in the case of the first dorsal interosseous. The last muscle to talk about is the adductor pollicis. The adductor pollicis is in the web space between the thumb and index finger. There are 2 heads. There's a transverse head and an oblique head. I don't care that you really know the difference between the two. But the adductor pollicis, even though it's going to the thumb, and you would think it's a median nerve, it's actually innervated by the ulnar nerve. So obviously, a potential test question is, what is the one muscle that has an action on the thumb that's not innervated by the median nerve? That would be the adductor. Let me just give you a little heads up. When we get down to the foot, you have all the same muscles in the foot. So you don't have to relearn all this stuff again. Here are the innervations and actions of these different muscles. And it's not really, as long as you know about where they start, originate, and insert, you can sit there during the exam and really easily figure out what action you're dealing with. Now, one of the things that's going to be important is I want you to pay attention to where the innervation occurs. If you have an injury of, let's say, the radial nerve up here in the axilla, you're going to affect extension because the radial hits the posterior compartment, triceps, right? You're going to affect extension at the elbow, and you will affect extension at the wrist because the radial gets all the extensors. If you have a lesion of the radial nerve in the elbow, you'll still have range of motion, extension at the elbow because the nerve gave off to the muscle belly up here, above the lesion, but you would have no extension of the wrist. Similarly, if you had a lesion of the median nerve down here in the wrist, you're not going to affect the median nerve's innervation of the Flexor carpi radialis or the digitals or anything like that because the muscle belly's up here. The only thing that you would impact would be the thenar eminence and the two lumbricals. Those are the only two that are innervated in the hand by the median nerve. Everything else in the hand innervated by the ulnar nerve. Here's all the rest of them here. A couple of diseases related to the upper extremity. This is a disorder where the palmar aponeurosis begins to sclerose down. It shortens and it tightens. So the palmar aponeurosis goes up into the digits. And what happens is the digits start to sclerose down like this. Usually involves the third and fourth mostly. And you can't straighten them out. That's called Dupuytren's contracture. The way you fix it is quite simple. All you do is go in there and you excise the palmar aponeurosis, and that releases the fingers. It's a simple surgery. By the way you fix carpal tunnel syndrome is you just cut through the flexor retinaculum. That releases the pressure. I think I'll say that later on. And why there's a picture of a penis here is because the penis has an aponeurosis on the shaft. There are a high percentage of people with Dupuytren's contracture also have contracture of that aponeurosis around the penis, and that's called Peyronie's disease. When they get erect, because of the scarring down, the penis will curve and it's painful. And it's also difficult to use. Okay. So there's a correlation between the two. I know you guys are not old enough, but Ronald Reagan, when he was president, he had surgery for Dupuytren's contracture. There was no mention in the paper about whether they kind of operated on another part of his body at the same time.
Can you fix that?
Yeah, you just go in and, just like the Dupuytren, you incise the aponeurosis, I'll call it an aponeurosis, and that'll straighten the penis up, or allow the penis to be fixed. Mallet finger is when you wind up with an avulsion type fracture of the extensor tendon from the distal phalanx, or it's the extensor expansion really. And what happens is, because you can't extend that digit, the unopposed action of the flexors will eventually draw it down. And that's what happens happens with these nerve injuries in the hand is you have tension on both sides at all times. If you lose one, the other side will pull it down. It's kind of like when we talk about the eye movement muscles. If you have a problem with one muscle, the other one will pull it, and you'll have strabismus, cross-eye, lazy eye, whatever you want to call it. Mallet finger, you have to surgically correct this, or it will stay like that. A lot of people have this, actually, mostly, rural folks that, so what? Farmers, so what? I can still use my finger. You see it a lot. This is carpal tunnel syndrome. There's the carpal tunnel right there with the flexor retinaculum over it. There are two tests for carpal tunnel syndrome. It's Tennell's test and Phelan's test. Tennell's test is what you do is if you take their hand, turn it upside down, and extend their wrist like that, and tap on the median nerve. If they have carpal tunnel syndrome, that sends little lightning bolts down into these 3.5 fingers, okay? Phelan's test is if you get them to put their, the backs of their hands together up here high, like under their chin high. Don't hold it down like that, but up here high. That puts pressure on the compartment. And after about a minute of them doing this, they will start feeling numbness and tingling in the affected side. So remember Phelan's and Tennell's test. And of course, as I mentioned, the treatment for it is to just go in there and incise the flexor retinaculum. And you have retinacula, by the way, on the extensor surface. You'll see them when you remove the skin. But the flexor retinaculum is really the only one that's clinically relevant. You also get what's called claw hand if it's untreated, right here. And what it does is they call it ape hand here because it looks like a monkey's hand, or ape's hand really. What it is unopposed action on the fingers that are innervated by the median nerve. This is claw hand in ulnar compartment syndrome. The ulnar compartment is back here at the elbow. This is your funny bone. You hit the funny bone right there. Right there, there's the aponeurosis that it dives through. If you get inflammation in that area, pitchers, carpenters, things where you're using your elbow a lot, can develop carpal tunnel syndrome. And what it affects is going to be this 1.5 finger here, and you'll wind up with claw hand. And there's a little description of it right there. And basically, I don't care that you understand the mechanisms of these ape hands, claw hands. Just understand that if you lesion the nerves going to the hand, because of the unopposed action, you're going to get movement of the fingers. This is falling onto your outstretched hands here. If you fracture your forearm, falling forward produces a type of fracture called a Colles fracture. And a Colles fracture is also called a dinner fork deformity because the distal fragment is always on the dorsal side. If you look at the hand, it looks like, if you look at the wrist, it looks like a dinner fork. I mean, it really does. You turn it to the side, it looks like a fork. It can involve one bone or both bones. Most of the time it just involves the radius because the radius takes the brunt of the weight. Colles fracture. Its counterpart is Smith's fracture, or also called a reverse Colles fracture. Smith fracture usually occurs when you fall backwards onto your outstretched hands. And in that case, the distal fragment is ventral. And it's also called a garden spade deformity because your hand looks like a shovel. These are, of course, orthopedic cases. You know, that have to have them realigned, maybe surgery, and certainly casting. This is what I was talking about when I was discussing the fractures of the surgical neck and the mid shaft, and I said, you know, there are other types of fractures, but I'll hold off on them. Now, this is what here we are. A spiral fracture, especially in a kid, is child abuse until proven otherwise. And a spiral fracture occurs when you grab that kid and you twist them like that. The twisting motion will twist that bone and form a spiral fracture. You just don't get them any other way.
Does that hold up in court? Or, I mean,
Oh, yeah.
Like spiral fracture is abuse.
Yeah, yeah. But usually spiral fractures, if you've traumatized the kid enough to have a spiral fracture, you need to do a full body x-rays because you're going to probably find healed fractures in other bones. You'll find bruising of different stages of resolution, you know, yellow, black and brown, red, different age bruising. One thing is you always have to watch out with linear type bruising. Linear type bruising is when you take something like that and I'm smacking you on the backside, you know, that I'm hitting you all up in here, down your butt and your legs. This one may be yellow, orange. This one down here is more red, you know, like they're different. You're beating them over time. So there are a whole bunch of things related to child abuse. You'll get lectures on it when we get to pediatrics. It's pretty awful. It's incredibly frequent in this state. If you go out I-40 east to like Eufaula, they have billboards. Even there, I guess it's rampant. Domestic abuse is rampant in the Native American population. I mean, they have freaking billboards to say, you know, we have to stop this. Domestic violence, child abuse, and that sort of thing. Wrist drop is a radial nerve injury in the elbow or higher. And you just can't extend the wrist. And Paul, no doubt you've had this problem, judging by your alcoholism. So, you remember how the radial nerve wraps around the humerus? So he's drunk and he passes out in Mardi Gras like this. And his radial nerve is between his bone, his head, and this chair. So when he wakes up after 14 hours, what do you think is going to happen with his radial nerve? He has wrist drop now. So, in addition to Paul, who else in here has experienced that? Oh, we got
I slept wrong.
So, wrist drop is something you'll see. It's called Saturday night palsy. It actually has a name, Saturday night palsy. Green stick fractures are here. Green stick fractures occur in children because their bones are a little bit more pliable. You take a green stick, not a dried stick, but a green one, and you crack it and you break it, what happens? One side will stay intact. So that's what happens with, in some kids, green stick fractures. You don't find green stick fractures in adults. The whole bone will break in adults. Compartment syndrome is something we'll talk about now, and then when we get to the lower extremity, it's more relevant, it's more prevalent there. You have the interosseous membrane, and then you have the deep fascia overlying the muscles. That produces an immovable object. So if you have swelling within either in the flexor compartment, which is more common, or the extensor compartment, which is shown here actually, it has no place to go. It can't go ventrally or dorsally because of the interosseous membrane. It can't go towards the outside because of the deep fascia. So pressure builds up. It will cut off the blood supply because it impinges on the vasculature. No blood supply irritates the nerves, and the pressure also impinges on the nerves. So in compartment syndrome, you have swelling, as you see here. You have paresthesias, numbness, tingling, pins and needles, and you have a cold extremity because of the shut-off of the blood supply. A delayed capillary refill, 4 peripheral pulses, and what you have to do there is you have to open up the compartment. You have to either do a fasciotomy, which is the most common thing, where the surgeon actually just makes a little nick, gets down to the deep fascia, and you've got a pair of scissors this long that are open on the end, and you just run it down through that little hole, and you just slice open the fascia, the deep fascia.
The entire thing?
Yeah, you just go down as far as you can reach. The scissors are long. It's called a fasciotomy, very easy to do. I mean, not easy to do, but that's one of the treatments. Otherwise, you're going to lose the limb. Okay? And it's usually involves a trauma, you know, like even so if you were hammering or something and you hit your forearm up here, you know, you break blood vessels inside, or there's movement of fluid out of the vascular space into the surrounding tissues, that's going to produce compartment syndrome. People who get trapped between the bumper and the building or something like that, lower extremities, or construction workers, these things are common. Compartment syndrome is common. What you do to monitor it, you know, of course it's a medical emergency. You send them to an orthopedic surgeon, and they actually stick a probe into the compartment to measure the pressure inside the compartment.
Can lymphedema produce the same thing, or is it the entire lymph?
It's within that compartment.
So it can be compartment?
Yeah, it's within that compartment. You have 3 compartments down in the lower extremity we'll talk about, 2 in the forearm. You don't get compartment syndrome in the humerus, in the brachium, because there are no compartments. It's down here in the forearm that you get compartment syndrome. This is the paronychia. We talked about this when we talked about inflammation yesterday, and this is the digital block. You see the person going into the base of the finger. Instead of injecting that anesthetic into there, which is really going to hurt, just inject it down here. It still hurts, but it anesthetizes the whole finger. And only on 2 occasions, and this happened to me last Wednesday. No, was it Wednesday? Friday. Friday. I got ready to say something to you guys, see if one of you wanted to go. Friday afternoon, I went over, they called me, there was a woman that needed her toenail removed because it was ingrown and was all pus filled and stuff like that. She'd been on antibiotics, it was rather painful, and there was nobody to remove it. So I left here about 3 o'clock and ran over to Good Shepherd and removed her toenail. And you do it the same way, you do a block the same way. I go down the side, down the other side, and across the bottom, because that's where the nerves are. But when you have big old fungal nails, for some reason it only happens with fungal nails. Sometimes you just don't get good anesthesia down here. So once I had put about 5 cc's of lidocaine in her toe, and she was still feeling me taking her toenail off, I just said, screw it, give me some lidocaine. I shot it right in her base of, right above her, I injected right there. A line across there, and that definitely got those nerves that are coming up from the underside. And then I was able to take the toenail off. So. Okay, any questions about that? Yes, ma'am.
When you inject something like that, how come, obviously it's not going to feel pain, but you can still feel pressure?
Yeah, that's what she feels. But, you know, and so I'm to take the toenail off, you take a hemostat like you have downstairs, and you just run it underneath the nail to separate the plate from the bed. And I tell them, I said, you're going to feel pressure, but I want to know if you feel pain. And when I got that hemostat almost all the way down to the end here, she said, ow, you know, I said, okay, no problem. And so I just touched her up a little bit. This is a test called Finkelstein's test, due to an it's due to a tendonitis of the snuff box tendons. And it's mostly the abductor pollicis longus, and the extensor pollicis brevis. And the way that, if somebody comes in and says their thumb hurts, and it's usually due to repetitive use of the thumb, like gripping a hammer or skiing on a weekend where you've overused it. Finkelstein's test is you just take the thumb, have them take the thumb, put it across their, flex it like that, across their palm, wrap their fingers around it, and ulnar deviate the wrist. And that will just light them up. That's called de Quervain's tenosynovitis. What?
I had it.
She said,
And
"You had it?"
it was really bad.
Man, y'all are just a wreck.
I got
Yeah,
injections
did
in
they do
mine.
Finkelstein's test too?
I just realized it.
Oh, you
just
have it
happened.
now?
Yeah.
Oh, you have it now? Oh.
I mean,
I don't remember.
it doesn't feel good, honestly.
So what seriously, I guess, since we
It's just it's a tendonitis, you know, rest, ice, elevation, non-steroidals, that sort of thing. This is called gamekeeper's thumb. This is the original name of it, gamekeeper's thumb, because what happens is back in the early 1900s, 1800s, they would have pigeons or quail or whatever they were eating. They would have to kill a million of them a day. You take the bird and put your thumb and index finger over their neck and pull them like that. Kind of pop their head, pop their neck, or pop their head off.
That's awful.
Well, yeah, but that's, if you gotta eat, you gotta eat. So anyway, you're pushing down on your thumb like that to pop the head off, and then do it again. So it's a repetitive motion thing. Over time, you wind up doing damage to the ulnar collateral ligament at the MP joint of the thumb. Now today we call that skier's thumb because you've got your hand around the ski pole, and the ski pole gets caught on a tree or the ski lift or something, and you hyperextend your thumb or abduct your thumb, and it tears that ligament. This is a surgical deal. even if you don't have bony fractures like you see up here, if you tear that ligament there, it produces a lot of laxity in your thumb as well as a lot of pain, and it's a surgical repair. You send these people to a hand surgeon. We actually had a case of this just a couple of weeks ago over in at Good Shepherd. And of course, the second year student that was there said, "What is this? What ligament is torn?" You know, just so this is something you'll see. Okay. Scaphoid fractures. So the scaphoid bone here is probably the most relevant one of the wrist because, again, it bears a lot of the weight on the fall. The problem with the scaphoid bone, though, is it receives its blood supply from only one end. And it's actually the distal end where the artery enters. So if this is the scaphoid right there, I said it's called navicular also. Navicular means boat because it looks like a boat. The artery comes in this direction. So if you fracture through there, it's the proximal segment that will degenerate or undergo avascular necrosis. And the more distal the fracture, the more likely you'll have avascular necrosis here. Anytime somebody comes in with a wrist sprain, you make sure you pay particular attention to that scaphoid. The scaphoid sits at the bottom of the snuff box. So you press on the snuff box and document that there is no snuff box tenderness. If there is snuff box tenderness, then you need to follow it closely, either yourself or you need to refer them to an orthopedic surgeon. Because if you lose the scaphoid bone, that affects the thumb. In this illustration here, there's the fracture. You can easily see the fracture there, in that case up there. You see how this whitish out area is? That's avascular necrosis right there. Right here, they've gone and put a screw in it to bring the two sides together. This is one you don't take lightly. So, and you document that snuff box tenderness or not, okay? This is an injury called degloving. These are usually due to farm accidents or industry where you get your hand caught in some type of machine. But removal of the skin like this is called degloving. Obviously, this person's going to be, all of these people are going to be referred to for surgery, same day surgery. So, there are different types of injuries here that you see. When you skin your knee, that's an abrasion. You can see the pinkish dermis there. That's why they're so freaking painful. The nerves are exposed. And this one right here, this is a crush injury. You see a lot of this in the ER. People have come in with parts of their fingers hanging off because of they slammed them in a car door or something happened like that. Lacerations that look like that, nice linear lacerations, never actually occur. They always look like that when they come in. And to put that back together, you have to just start tacking things together that result in a linear incision. In other words, what I mean by that is if you've got some laceration this looks like that. So what you want to to do is you want to start tacking things together. So tack this side to that side. Maybe this side to that side. This side to here. And that way you're producing linear things that you can suture up. If you just start down here, you're going to wind up with a freaking mess. It won't work. So start throwing sutures in different parts to take all these starburst things and make them look linear. What I would do with this one right here is I would put a suture there and maybe suture there, and now you've got a linear one right there. Then I would suture that to this and make a linear one there. And by tacking this thing down, now I've got a linear one there. So it's actually quite easy to do. But this is how 99% of them show up in the ER. Very few people actually, oh, I cut my finger with a knife. Most of it, I blowed my finger up with trying to kill a frog or something. This type of injury right here, you really have to watch out for. High pressure guns and high pressure washers, when they touch the skin, what might look like a little bitty pinhole on the skin could be the injection of all sorts of paint or latex or whatnot into the compartments of the digits and palm and forearm. These things are surgical, obviously surgical cases.
Is that paint that white on the bottom right?
No, it's some type of asphalt or something like that that's in there. This right here is probably some kind of paint. But, on the surface, it just looks like a little dot.
Yeah.
I had a guy one time that had some kind of high-pressure glue gun that hit his finger. He shot glue all up in his hand, and it was just a mess. So, this is the banging the ganglion with the book. And there's, you pull it out. See, it's not fluid filled like an abscess, so they really don't drain well with a needle. This is called a boxer's fracture. It can involve the 4th to the 5th digits. It always involves a teenage boy around the age of 16 or 17 who just caught his girlfriend in the back seat with his best friend, who was also 16 or 17. And it's always a cinder block wall that they punch, and it's always the 4th and 5th metatarsals that get the brunt of the thing. The way you cast these things is you try to straighten out the bone, and then you cast them with the finger in flexion, and that puts usually the extensor tendons to help splint the area. Here's a suboval hematoma. A lot of people, when they get these things, they hit their finger with a hammer. They'll take a needle, heat it up, and just stick a hole in the top. If it's acute, the blood will spurt out. The podiatrist, though, will tell you that anytime you have something like this, you actually need to take the nail off, because you don't know if there's a laceration of the bed. If there's a laceration of the bed, you need to suture it up. But most of the time, you'll see these cowboys come in with little holes in their fingers where they try to drain it. If you wait too long, wait 8 hours or more, then the blood will coagulate and it won't come out. And that's the end of the second test block. Yes, ma'am.
And they were talking about pulleys, like if it went away, but they said if it didn't go, they'd go in and cut a pulley. So it was
That's the retina. All right, see you in lab.
It's 4th and 5th. Yeah. For boxer's fracture. Oh, I already missed that. Yeah.
So that was, so it's.
Oh my god.
Friday off.
Yeah, Friday off. Oh yeah, cause is this the same thing?
Yeah, that one makes it fourth digit.
I like that app.
Oh, yeah, and then it's a lease.
Can I bring that iPad into lab?
Last time, I was thinking. What's that?
My wife?
What was it?
I'm just gonna get my brow up. Super interesting. Frustrating. I was judging you so hard.
It was fun time.
Really? Didn't it stink? It sounds terrible. Right. Yeah, never again. Don't knock it till you try it, but you tried it, you're knocking it.
I'm thinking about it now, because I think what's on here is like,
I feel like I have a